Okay, we're busy with a new series or course. It's been called Adaptation of the Normal Newborn Baby. I'm Anna Nolte, and this course only exists of 2 lessons. In lesson 1, on the part 1 part, we will discuss mostly the adaptation that happens in the respiratory and the cardiovascular system of the baby, and also a little bit about glucose metabolism. And then in the second part, we will discuss all the other body adaptations that happen during or after birth. So as I've said, in this lesson, we will talk mostly about the adaptations that happen in the respiratory system and also in the circulatory and in the glucose metabolism. Now, when we look at the adaptation, the pulmonary adaptation, when the baby is term, everything is already ready, if I can call it like that, for the baby to start breathing the moment that it's been born. There's enough alveoli and surfactant already been formed in the lungs, are completely formed. The fetus already makes respiratory movements in utero, so he literally exercises his respiratory abilities. But the lungs are also filled with fluid, and that's one of the big adaptations that need to happen after birth to get rid of the fluid in the lungs. And then also the lungs are being lined with surfactant. I think all of you know surfactant. It lines the inside of the alveoli and it reduces the surface tension within the alveoli. So it keeps the alveoli open so that the baby doesn't need to take a huge, big effort every time that it inhales. If we look a little bit more in detail at surfactant as such, it's a slippery detergent-like substance, and it's already there in the alveoli from 24 to 25 weeks of gestation, although not in a sufficient quantity. It's usually only after 34 to 36 weeks of gestation that there's sufficient surfactant, but it already starts being present from 24 to 25 weeks of gestation. Now, as we've said, it lines the inside of the alveoli, and it causes the alveoli to stay open when the baby exhales. If there's not enough surfactant, then the alveoli will collapse every time that the baby exhales. Now, the surfactant secretion increases also during labor and after birth, so it's not fully developed, if I can call it like that, when the baby is born. It's still in the process of being formed during and immediately after birth. If the mother goes into preterm labor, we can usually give her steroids, and the steroids helps to stimulate the formation of surfactant and speed up the maturation of the lungs in that way. Now, if we look at what happens during birth, is first of all, near term, the amount of fetal fluid that the lungs produce decreases in preparation for birth. And then gradually this fluid starts being absorbed during early labor, and so that by the time of birth, only 35% of the original amount of fluid still remains. And the extra fluid is then being squeezed out of the lungs during the birth process, or it is being absorbed by the blood and the lymph in the lungs immediately during birth and immediately after birth. Now, the first breath of the baby is a very important happening in the life of the baby. Now, first of all, during the vaginal birth, specifically, the fetal chest is being compressed. And as we've said on the previous slide, a lot of the fetal, lung fluid is being forced out of the lungs into the mouth and the nose. Now, at birth, the remaining fetal fluid goes out of the alveoli, has been forced out of the alveoli into the interstitial spaces around the alveoli, so that there's now space for air to enter into the lungs. Now, when the pressure against the chest is released at birth, First of all, it causes the chest to recoil, and that causes a small amount of air to enter into the lungs. And that breaks or reduces the amount of the negative pressure that's really needed for the first breath after birth. So the alveoli opens a little bit. The surfactant that lines the inside of the alveoli keeps the alveoli open, so that with the first breath, immediately the air enters into the alveoli stays open. And as we've said, the fetal lung fluid moves now into the interstitial spaces where it's been absorbed by the pulmonary circulation and the lymphatic system, so and eventually been removed out of the lungs. But the complete absorption of these fluids is not like in only immediately during birth. It might take several hours before all the lung fluid has been absorbed. What stimulates the baby to breathe during labor? There are a few things. The first one is the gas changes. There's an increase in the CO2 and there's a fall in the O2 because now the placenta and the umbilical cord is not functioning as it should anymore, and this changes in the CO2 and the O2 and the pH in the blood stimulates the chemoreceptors that's been situated in the carotid arteries and the aorta. It's the same chemoreceptors that we were talking about when we did the CTG, and the same chemoreceptors that's been stimulated in the fetus when there's a decrease in oxygen and increase in carbon dioxide. And these impulses from these receptors, from these chemoreceptors, stimulates the respiratory center, and that triggers the respirations of the baby. The second big thing that causes the baby to start breathing is temperature changes. The baby moves from this warm fluid-filled uterus, it's a body temperature environment for him, and then he moves into a much cooler space, into the labor ward. And even if the labor ward is not too cold, it's usually somewhere in the 20s, it's much colder than the 37 degrees in the uterus where it was. And then also his skin is wet because of the liquor, and that causes evaporation, and that we know also causes the baby to cool down. Now, the sensors in the skin respond to the sudden changes in the temperature, and they also send impulses to the respiratory center, and that also stimulates then breathing. Other stimuli that does the same, that also stimulates the respiratory center, would be the changes in light. The baby comes from a dark environment to a light environment. There's sound changes, there's smells, there's pain at delivery, and all these stimuli as well stimulates the respiratory center, and the baby starts breathing. Now, if we look at the cardiovascular adaptation, what happens in the cardiovascular system? And this goes around, to a large extent, about these three shunts that closes just after birth: the ductus venosus, the foramen ovale, and the ductus arteriosus. And I will show them to you just now on a diagram. But in the fetal life, they carry much of the blood away from the lungs because there's not really blood necessary in the lungs. The lungs have no function except they just need blood for themselves to be kept alive. And so these shunts are carrying the blood away from the lungs. Then with birth, and there's now quite a high pressure in the lungs because, as we've said, the lungs are not functioning. Now, during birth, when the lungs are now being collapsed, these high pressures collapse, and that makes that initially a small amount of blood goes into the pulmonary vessels, a little bit more than what normally was, and then at birth these shunts close and the pulmonary vessels dilate, so that the blood pressure in the lungs decrease to a very large extent. So that makes that much more blood flows now to the lungs than before the birth of the baby. And the clamping of the umbilical cord further contributes to this. And here you can see the 3 shunts. The blood comes with the umbilical vein from the umbilicus, from the placenta, and it goes through the liver, and here it attaches to the vena cava inferior to take blood, this oxygen-rich blood, to the lungs. Now, the moment that the umbilical cord is being clamped, this is not being necessary, and this ductus venosus is then one of the things that closes so that the vena cava inferior can act as a normal vena cava inferior as in a mature body. The second shunt here is the foramen ovale, the shunt between the atriums, the left and right atriums, and we will come to the closure of that just now. And the ductus arteriosus is the shunt here between the vena cava inferior and the pulmonary artery, and as the pressure in the lungs decrease, this ductus arteriosus also closes. Now, what happens in the lungs regarding the circulation? Now, first of all, with the first breath, there's now a rise in the oxygen concentration because, as we've said, the alveoli opens, it stays open, and oxygen can go into the lungs. And that causes the ductus arteriosus to constrict because obviously that is now not necessary anymore. And then the pulmonary blood vessels respond to this oxygenation by dilating. Remember, we've said there was not a lot of blood necessary in the lungs during the fetal stage, but now there is a lot of blood necessary for proper to take the oxygen away out of the lungs, etc. So that makes that the lung vessels, the pulmonary blood vessels have to dilate so that more blood can flow to the lungs. And at the same time, the fetal lung fluid is now also being removed by the blood and the lymph as there is now an increased circulation. And this, it decreases the pulmonary vascular resistance, in other words, the pressure in the lungs by 80%. And that allows the vessels to expand and to allow for the suddenly increased blood flow from the pulmonary artery. It makes, literally opens the vessels in the lungs so that blood flow can. Now, what happens in the circulation in the heart immediately after birth? Now, at birth, the pressures between the right and the left sides of the heart are now reversed. The sudden dilatation of the vessels in the lungs allows that blood flows now much easier and enter freely into the right ventricle, because previously the higher pressure in the lungs have caused a higher pressure here, and it decreases now the pressure in the right side of the heart because the pressure in the lungs are now much less. And the umbilical cord that's been clamped, as we've said, causes the ductus venosus to close, and that further decreases the pressure in the right side of the heart. And that the increased flow from the pulmonary veins on the left side causes the pressure on the left side to be higher, and that causes the foramen ovale to eventually close because of the differences between in pressure between the left side and the right side of the heart. Now, when we look at the blood glucose maintenance, a little bit different from the cardiovascular changes and the respiratory changes. Throughout gestation, glucose is being supplied to the fetus by the placenta, by the mother. He gets all his glucose sources from the mother, and he stores them in the liver and also to a certain extent in the skeletal muscles so that he can use it after birth. Now, the birthing process is a very hard working process for the fetus and the baby, so that these stores are completely depleted within 12 hours after birth, because he uses now a lot of energy in the stress of the delivery for the breathing to produce heat, because he's losing a lot of heat in the process, he suddenly has to start moving outside the uterus, and all the activation of all the functions, and all those needs a lot of glucose, and obviously his brain needs most of them. And glucose is the primary source of energy for the brain. So if there's not enough glucose, the brain will obviously suffering from that. Now, we say that the glucose concentration in the blood commonly falls to the lowest level by 60 to 90 minutes after birth. And this is very important to take into consideration when we talk about the baby's first feed, the first breastfed or feeding, or the first bottle feeding if the baby is being bottle fed. Now, there are certain babies that are high-risk babies for hypoglycemia or low blood glucose levels, and one of them are big for gestational age babies, and specifically diabetic babies, because they are very used to the high levels of blood glucose that they get from their mothers, and they produce excessive insulin in order to get this high levels of blood glucose out of their bloods into storing. Now, the moment that they're being born, the high blood level glucose levels from their mothers are being cut off, but they still have excessive insulin, and that makes that the babies very quickly develop hypoglycemia. Now, infants that's also exposed to stresses, for example, asphyxia or some other infection, use a lot of energy in the process to try and breathe, if I can call it like that, and they also exhaust their stores of glycogen very quickly. So it is important to remember in the case of an asphyxiated baby that the glucose or that the baby might get very quickly hypoglycemic. In the next course, in the next lesson, we will see how the influence of how to produce heat will have on the glucose metabolism. But a cold stress baby uses a lot of glucose in order to increase his metabolism and to raise his body temperature. So that's why it is so important to prevent that the babies are being cold during labor, and to keep them as warm as possible, because they have very little glucose and glucose stores. They can't really afford to use any of them to produce heat. And that brings us to the end of lesson 1. I hope you've learned again something new, and you have to complete your quiz before you can continue to the next lesson. See you in lesson 2.